we've heard about a few, price transparency or, tools out there. Anything you've seen or anything new developing in the market that may be helpful for healthcare providers?
Well, we'll talk about some aspects of price transparency in the future, but keep in mind that price is only useful if it's for equivalent quality and equivalent outcomes and service. And one of the things that we don't have in our industry is an ability to truly measure outcomes and service. I know, living in the trenches, that certain doctors and certain hospitals do a better job. For example, STS, the Society for Thoracic Surgeons, has a very robust way of grading quality. So you can be a 3-star, a 2-star, a 1-star hospital. But when the payers negotiate, they don't give you any more credit for 3 stars than for 1 stars, even though the outcomes are definitely better. And when you look at a lot of the academics out there publishing information about price, they don't talk, the quality they use are these knucklehead standards that were developed by CMS. And so as a result, this whole issue of price is important, but it has to be accompanied with the issue of outcomes and service.
Knowing at your slides, I guess I should say, how does a commercial pricing strategy work?
If you turn to the next slide, what you'll see is a matrix of how I look at, people say, well, you're charging 300% of Medicare or 250% or 400% of Medicare. And when I try to analyze or develop a pricing strategy for an organization, this is the kind of matrix that I use. The first thing you do is, this is a hospital with 63% Medicare and Medicaid. Medicare in this case is paying 85% of cost, Medicaid 80% of cost. And people say, well, what about 340B? 340B is just a workaround to compensate for underfunded Medicare and Medicaid. That's another story altogether. But then, because in this new environment that we have, which is new, most of or a significant percentage of the admissions are going to come from your medical group. So you have to add the cost of employing and retaining physicians. And then most health systems now, or hospitals, are part of health systems. And then there's system overhead. The idea that there's going to be economies of scale. There aren't economies of scale in a system. There are economies of expertise. So when you add that, plus the fact that because of all the Medicare Advantage programs, the rate of denials and delays and downcoding has increased dramatically, you need to add a load for that. What's the point of getting a 5% increase if that 5% increase is going to be taken away by the fact that there's going to be more denials? So it's a very simple math problem, just addition and subtraction and multiplication. And at the end of the day, this hospital, just to break even, needs 230% of cost, which represents 271% of Medicare. Now, the question is that good or bad? And the answer is neither. It is what it is. And so can most health systems, as I said, improve efficiency? Yes. Are many of them dysfunctional? Absolutely. And they need to address it. But that doesn't mean they still need to be able to generate what they need to from the employers in order to survive. And one last point about this, if the health system doesn't get 270% of Medicare, they're going to start cutting services. The first to go is inpatient mental health. The second is rehab. The next is home health. And one of the things that we've done, by the way, to address that is, because in many cases, these adjacent services are not performing well, and the health system doesn't necessarily have the competency to operate these systems, is we've done joint ventures, for example, with a hospital home health agency and a for-profit, so that in home health, it's all about expense and efficiency.
Right.
The hospital didn't have the tools to do it. They now have a relationship with an organization so they can still govern what goes on, but get the expertise they need to do well.